Hello team, it's Wednesday night. We're here for Q&A. It's Dr. T and I have an incredible array of fertility and gynae questions that have come across my desk today. And I've got to tell you, there's some stuff there that I had to go and do some reading about. So welcome to Wednesday night here in Perth, Western Australia. It is awesome to have you guys on. Fantastic. Let us know where you're coming from. And we will get started. Beautiful to see everybody's faces. Say hi. Hi. Whether you're coming from here in Perth or interstate or overseas, it's really great to have you. Now, I do want to start by saying the things that I'm going to be talking about tonight are very generic. I've tried to keep things as generic as possible. If you haven't got all the answers to all your questions pertaining to your particular situation, then I would highly encourage you to head along to your doctor, your fertility specialist, your endocrinologist, and get as many of your questions answered as you can. All right. I'm a bit croaky today. I've been talking an awful lot over the last couple of days. Okay, so in no particular order, let's see if we can tackle some of these questions. The very first question that was asked is, what is the best prenatal multivitamin recommended for preconception? There are so many different brands that are on the market, each spruiking their own positive benefit. It's really confusing. Totally agree with that one. There are so many options. But you know what? That's not just the issue with multivitamin preparations in relation to conception and fertility. It's the same across every single condition. There are combinations out there for hair, skin and nails, combinations out there for postmenopausal women, stressed out women, like which is the right combination and permutation. The reality is we don't actually know. But what I can tell you about as far as vitamins and minerals, and somebody else asked this question, what should I be having from a nutritional point of view? As far as supplementing goes, the only nutrient we really care about across the board for everybody, a little drum roll on this one, is folic acid. And that has been conclusively proven in large-scale studies dating back to the early 90s that if we are not replete in folic acid leading into pregnancy, and you need this in place for at least a month before trying to conceive, you are at increased risk for developing neural tube defects. And so the most common one we know about is spina bifida. Large-scale studies have proven this beyond a shadow of a doubt that we need folic acid in our diets. Now, much of our food has now been fortified, so breads and cereals are fortified with folic acid. However, the RANSCOG recommendations are for at least 0.4 milligrams or 400 micrograms in a multivitamin preparation. Interestingly, in New Zealand, who's part of the RANSCOG group, Royal Australian and New Zealand College of Obstetrics and Gynaecology, they actually recommend 800 micrograms. So it might be in their particular population, they are seeing a greater deficiency. Maybe they don't have fortification like we do in our foodstuffs over here. So 400 micrograms of folic acid on a daily basis in place at least a month leading into you trying to conceive. There are some preparations out there that have more than that. I won't name the brand, but there's one particularly that has 800 micrograms. Is it likely to do you any harm at 800 micrograms? Absolutely not. There are some random studies that have looked at risks of colorectal cancer, but I'm talking about like milligrams of the stuff, 10 plus milligrams of the stuff per day. If you are at risk already of neural tube defects, diabetes, previous family history of spina bifida, for example, twin pregnancy, it is recommended for you to be having 5 milligrams. So not just 0.4, but 5 milligrams per day. So make sure you check in with your healthcare practitioner to see what is the appropriate dosing for you. But to be perfectly honest, out of all of the necessary nutrients, that's really the only one. So all the other stuff in the multivitamins probably isn't essential. Now, some people will be deficient in things leading into pregnancy, such as iron or vitamin D. They might not be getting enough omegas in their diet. Those things are fantastic, but that's an individualized assessment. But across the board, the only nutrient that you must be supplementing on leading into pregnancy is folic acid. So, sisterhood, keep it simple. You can actually get nutrients on the market that just have folic acid in them and nothing else. So you don't have to be worried. I'm just worried about my power supply. I have so many cords under my desk. I think we're plugged in. So back where I was. There are so many combinations and permutations out there, but really you can keep it really simple by just having a pure folic acid supplement and then adding in the other things that you might be missing out on. So I'm hoping that also might address the other question. There was another question here about what is my opinion on vitamins and minerals and nutrition affecting fertility? Well, that pretty much is it. And it's probably not so much in relation to fertility, it's in relation to just preconception, healthcare, and optimizing the temple. A lot of people, and this particular person, is spending lots of money on supplements, CoQ10, iron, vitamin D, brand name multivitamins, also seeing a fertility nutritionist, helping with diet. What are the things we should be focusing on? Well, as I said, fairly basic supplement. I think when it comes to nutrition, the women's health study, a nurse's health study that was done over some 50 years longitudinally, looking at over 10,000 nurses, looked at the most fertile group versus the least fertile group. And they compared the difference in diets. And what they actually found is that the fertility diet, so to speak, needs to include some whole fats, preferably your unsaturated, polyunsaturated fats. It should include an abundance of fruits and vegetables, soluble and insoluble fibers, probably whole dairy, so your full fat milks, and lean meats in there, as well as some good quality oils. Now, that would actually have a very typical appearance in the Mediterranean diet. There it is again, the Mediterranean diet, good for so many aspects of our health. But there's no real other sort of concoctions or combinations of foods that have been conclusively proven to improve our fertility or reduce our miscarriage rates. So have a moderate diet, optimizing those fruits and vegetables, getting those good oils in, getting some meat in or meat alternatives if you are a vegetarian or vegan. But aside from that, there is nothing really specific. I would be really watching weight. I think too much weight or too little weight is probably way more impactful on your ability to conceive and keep a pregnancy than the different types of foods that you are putting into your mouth. Some people would put a little bit more focus on omega-3, particularly with relation to endometriosis. The jury's a little bit out on that endo diet, but certainly that might be something to focus on. And being vitamin D replete is also really important. So whether you get that from a dietary source or the sun is up to you. And then making sure, of course, that you have adequate iron. But aside from that, from a nutritional perspective, there is nothing else. There is no magic berry from the top of a mountain that is necessarily going to improve your fertility or reduce your miscarriage rates, aside from just a moderate Mediterranean type diet. Okay, nor is there any fantastic research studies on this stuff apart from the nurse's health study. Okay, now what else? Here's another one. Here's a PCOS question to anyone out there with PCOS or anyone who knows anyone with PCOS. Do women with PCOS and a high AMH, now let me tell you, having a high AMH is pretty much universal in PCOS. So women with polycystic ovarian syndrome often have a really high ovarian reserve, as indicated with the biomarker AMH. Do women with PCOS and a high AMH go through menopause later in life than other women? Would you believe they do? We know that women there's such big ranges of anti-Müllerian hormone values at any one age in life. But we do know over the period of our life, the AMH does drop, but it drops in a fairly routine gradient, such that if someone has a really high AMH, their gradient is going to hit zero at a much later time in life than someone who has a really low AMH. So in fact, yes, women with PCOS and a high AMH do in fact hit menopause much later. But the second aspect to this question, are the fertile years extended in women with a high AMH and PCOS? No. And I think we all know the reason for this, and that's age. We know that the biggest impact factor on your ability to conceive is your age. Your age affects the quality and the quantity of eggs. Even if you have a really good quantity because you have a high AMH, but you're 40, your chances of conceiving are going to be consistent with just being 40 years of age. So no, the fertile years are not extended in women with PCOS and a high AMH. Someone else has asked the question, is it possible to get regular periods yet not be ovulating? If yes, how? What a great question. Thank you for asking this question. Would you believe that yes, you can have a regular bleed? I'm not going to call it a period, but I'm going to call it a bleed. You can shed your lining without actually ovulating. And I wouldn't say this is something that goes on for years and years and you're not actually ovulating, but in fact, your lining can come away even though you haven't actually ovulated. And you might think that it's happening in a really regular way, but perhaps it's not actually as regular as you think. So yes is the simple answer. Can I explain that 100%? No, I can't. But I know that you can shed your lining without actually having an ovulatory cycle. Can I please share more about the unknown egg donor process in Western Australia? So this is kind of specific for our West Australians here. Wave to me if you're from West Australia, give me some love. Let me talk to you about egg donation in WA, because every state in Australia is different and we are very different to the rules and regulations in other countries. So it can make it quite a complex process. But in Western Australia, you can all egg donation has to happen altruistically. In other words, you can't actually pay someone to get their eggs. I'll pay you 10 grand if you give me your eggs. You can't do that here in Western Australia. That's against the law. There are a couple of other things. Donors can either be through a known donation pathway or an unknown donation pathway. So the unknown donation pathway is generally through an egg registry or egg bank, if you like. And that's where people that you don't know, you have no connection with, you've not connected to in any way, choose to donate their eggs to a registry. And those eggs are frozen. And they supply the registry with some basic details: height, weight, eye colour, education level. They must provide as much information on their medical history, their genealogy, as they possibly can. And that's about it. And then those eggs are placed into storage under a registry number. So that becomes a number. Now, an unknown donor can donate to a maximum of 5 families, including their own. So if they've got kids, that's one family. And then they can donate to 4 other families, but as many children can come in that family. And that is the limitation in Western Australia. It's different in other states around Australia, and some states don't have any regulations around that. Every single donor, egg, sperm, or embryo in Western Australia, when they donate, they understand that the child born of donation has the right to identifying information of that donor when they turn 16 years of age. That's different in other states around Australia, but that is the regulations in Australia. And in fact, when a child is born from their donation, they are advised a child has been born from your donation. That's all they're advised, just that. So there comes a time when that donor-conceived child can contact the registry and ask for identifying information and ask to be put in contact with the donor. Now, that donor has no rights or responsibilities to that child, nor the other way around. In fact, they don't have to say, yes, I'm happy to be contacted. They can say no. But that connection is made through the registry. And that's why it's really important to have these registries so that potential for communication can happen later on in life. And all of these rules and regulations have been put in place to protect the future health and well-being of the unborn donor-conceived child. based on bucket loads of research that has been done over the last few decades where truly anonymous donation has occurred, and that has led to quite injurious health and mental health burdens for children born of donation. So that's the situation here in Western Australia. The known donation pathway, there are a few hurdles that need to be jumped along the way, but being known, it is something that you know. And some of the counselling that needs to happen around that is, when do you tell a child that they're born of donation? How do you tell them? What's the sort of languaging that you use? How do you refer to the person who might have gifted you with this precious gift? How do you relate them to the donor conceived child? So there's a lot of thinking that needs to be put in place before the donation process can occur. But I'm happy to talk about that in another session. Hopefully that sheds some light on the unknown egg donation process in Western Australia. It's a pretty amazing person who's happy to go through the equivalent of an IVF cycle to donate their eggs to someone they might never meet. Pretty incredible. Okay, someone else has asked a question. I was just curious if it's best to wait until the watery egg white cervical mucus to arrive, or is it just before or just after this time that's considered the most fertile time in the fertile window? I don't know if anyone else is confused by that, but I totally am. And I can totally understand why this process is confusing because we're waiting for the mucus to change. So we know that assessing cervical mucus is not really a very accurate way of determining when you've ovulated, because the consistency of the mucus is dependent on a number of chemicals, and those chemicals are dependent on the concentrations of hormones that are around. And so the change from the sort of stretchy mucousy discharge to then the thicker discharge is the change from an estrogen predominant environment through to progesterone. And that can happen within a couple of days, and you might have missed the window completely. So I feel that what is a way more accurate way of determining when to time your sexual intercourse is actually go to the pharmacy and purchase an ovulation home testing kit and actually determine if you're having an LH surge, because that's the hormone that we're testing in the urine, and then 12 to 24 hours after you see the LH surge, you're going to ovulate. So that's the window that you want to be basing your sexual intercourse around. That's a way more accurate way of assessing it than waiting for the byproduct of the follicle, which is the estrogen, or the ovulated follicle, which is the progesterone. So I personally don't recommend the cervical screening method. I think you're far more accurate in using an ovulation testing kit. If possible, can I address secondary infertility following the very easy conception of a previous child? And is this in any way related to having a cesarean delivery in the first? Awesome question. Fantastic question. Do you know secondary infertility is actually so much more common than we think? And the leading cause of secondary infertility is age of a woman. Because if you think about it, you're so much younger when you have your first child. And if you're having your first child in your mid-30s, when most of us are, finishing up with our careers, ready to move on to the next stage of life, you have your first child, you might breastfeed them for 6 months to a year if you're lucky. You might, want to get them out of nappies, maybe sleeping through the night. And by the time they're 2 or 3, you're ready for child number 2, and all of a sudden you're 38, 39 years of age. That by far and away is the biggest impediment for couples moving forward with their second child. Do I think that a cesarean delivery, particularly an uncomplicated cesarean delivery, is in any way related to infertility? No, it's a very unlikely cause. I might assess the tubal patency to make sure that hasn't been affected. I would always do an ultrasound in someone who presents with secondary couple subfertility, because there may be other things like a polyp or a fibroid that might be an issue. But it's highly unlikely unless there's an incredibly large Caesar scar that where blood is accumulating in and it's affecting bleeding rates and possibly causing some inflammation. But really, having a cesarean delivery and therefore a scar on the uterus is a very low likelihood for impacting on secondary infertility. More than likely, the most common cause is age-related, but of course, you would do a full fertility workup on somebody because there are things that can manifest that might have been a problem before, but have just tipped over and been an issue for this second pregnancy. Okay. I've had some pretty debilitating periods, a lot of symptoms pointing to endometriosis, including perectal bleeding when I have a period. That is a big red flag for me. I had an ultrasound. Doctor said there's no evidence of endo on there. Gave me a script for some pain relief. What do I do? Well, here's the first thing. I can say with certainty that an ultrasound is not a very accurate indicator of whether you do or don't have endometriosis. Usually, if a woman has deep and infiltrating endometriosis that causes significant disease, something will be evident on a really good quality ultrasound done by a gynaecologist who all they do all day, every day is scan women's pelvises. So I would always arrange for a tertiary level ultrasound to look for those subtle signs and to go looking for the signs of deep and infiltrating endometriosis. Even a physical examination can miss endometriosis. We know that that's not particularly accurate when trying to determine particularly superficial endometriosis. You might detect some nodularity in the pelvis or some fixity to the uterus or the ovaries on an examination, but even that is not particularly accurate. But I would do them because this is all about putting the pieces of the puzzle together. So the fact that there is bleeding perectum, 100% that needs to be investigated, probably by a colorectal surgeon, maybe with a colonoscopy to make sure there's not something else, or there could be deep and infiltrating endometriosis into the bowel itself, and that therefore needs to involve an advanced laparoscopic surgeon and probably a colorectal surgeon as well. Let's say all of that's negative. How do we manage these debilitating periods? Well, yes, you can try simple analgesia, Panadol, or anti-inflammatories, Ponstan, good places to start. More often than not, unless you're trying to conceive, we will go for some form of hormonal suppression. Even just the simple combined oral contraceptive pill and skipping the sugar-free pills so you're not having a period is a great way to manage these. But if you're not having success, particularly after a 6-month period of time of really giving simple analgesia and hormone suppression a go, I would definitely be considering a diagnostic laparoscopy to ensure that we have not missed pathologies such as endometriosis. So that would be my plan of attack. I would highly recommend whoever asked this question, if you did, that you seek a second opinion from perhaps a gynecologist who might have experience with laparoscopic surgery and management of endometriosis, because there are certainly some some concerning things about your history. But definitely go and seek a second opinion there. Alrighty, have I got everything? Oh, one final question. There's still some people on here. Give me some love if you're listening. I hope you are. I think I've left this question till last because I actually had to go and do some reading today on this. Somebody has asked the question, what are my thoughts on DQ alpha testing in relationship to recurrent pregnancy loss? Hello, everybody's listening. Awesome. And this is in the context of recurrent pregnancy loss in an assisted reproduction setting. So after IVF and testing of the embryos. What are my thoughts on DQ alpha testing? I have to be completely open, honest, and vulnerable here. I'd never even heard of it. I'd never even heard of DQ alpha testing. But when I went and did some reading, I realized it was part of the HLA tissue testing. So we all have different tissue signatures, and HLA testing is a way of identifying our tissue kind of signature. And the DQ alpha gene apparently sits on chromosome 6 and determines what our HLA tissue typing is. And allegedly, if a male and a female have matched DQ alpha genes, then the body's ability to accept a foreign body, i.e. an embryo, is significantly reduced because the male's DQ alpha gene is kind of masked by the presence of the females. Normally having a different HLA gene type means the body recognizes it as foreign and then allows the foreign embryo to be implanted. That's the theory. I think I've explained that about as well as I understand it. So the big question is this something that you would go looking at in relation to recurrent pregnancy loss? The very fact that it's not mainstream, the very fact that I didn't know anything about it, and look, I'm not the knowledge about everything, but if something is a well-known, well-researched, well-accepted form of managing something, then generally speaking, I would have read about it in the current literature. So when I went reading about it, the latest, most recent study I could find was 2015, was a large systematic review of about 14 studies. And in fact, the last, hang on, I'll come back to that question about wine in a second. It's an important one. The last study that I could find was 2005, I think it was 2005. So the fact that this stuff is not currently being researched, there's not massive big studies on this, kind of suggests to me that it probably is a great theory and it sounds like it might be true, but it has not been borne out in practice or in research. So the study I found from 2005 actually showed that this DQ alpha gene matching, so where the mum and the dad are matched, is just as common in people that can conceive as those who have recurrent miscarriage or recurrent implantation failure. So it's not something that's necessarily more common in recurrent implantation failure. The systematic review of all of the studies did suggest there might be a slight difference, but the quality of the studies were deemed to be really poor. So I think the jury is out as to whether it actually is an impact factor when it comes to implantation failure. And certainly the treatments, which are immunotherapy, intragam, immunoglobulins, big time immunotherapies, have also not borne out really promising results. And maybe that's because these things are so rare, they're so rare that you would need tens of thousands of people in order to do a study that actually showed a difference and showed that a therapy works. And so it's my belief that you would probably want to exhaust all of the other commonly accepted testings, diagnostics, and therapies before you would go down the pathway of these immunotherapies for these extremely rare and unproven things. And there's a lot of things that really fall in that category. I found a website, and I'm not going to name it, but it concerns me that there's T helper 1 and 2 cytokine testing and treatment. There's killer cell immunoglobulin-like receptor testing, screening for a whole heap of inherited diseases. Obviously, uterine biopsies are in there, uterine natural killer cells, and of course now endometrial receptivity assays, I suppose. They don't really, because it's not immunotherapy, but the fact that there's this big area, I think, would be reserved for someone who has not just had 3 or 4 embryos put back, but dozens, where every other possible cause, stone has been unturned, therapy has been tried, because this is really borderline stuff that there's not a lot of evidence on, and not without consequences in the pregnancy itself. So hopefully that answers that question. It was a really hard one. Thank you so much for asking it. I've just learned a whole new thing about DQ alpha testing, which is awesome. So now I'm just going to scroll back because I'm going to finish up really soon. But someone asked me the question, during the 2-week wait, how do you keep your sanity? Will one wine do any harm? Awesome question. I'm guessing you mean the 2-week wait from your timed intercourse or your embryo transfer through to your pregnancy test. Look, I'm going to be really straight up and frank about this. It's the most important time, right, to be doing all the right things, because implantation and early embryo development is during that period of time. Can I say one wine won't do any harm? No, I can't. In fact, the bottom line is we don't know the lowest limit of safety when it comes to alcohol consumption and pregnancy outcomes. So you kind of got to toe the line in this 2-week period of time. I can't say that one wine is not going to do any harm. It might, because we don't know the lower limits of safety. So my suggestion is to stop and think about, is wine really the treatment to dyscopia? You know, think about the fact that you're needing to revert to wine to cope with stress, worry, anxiety, because they're all the emotions that are coming out. Uncertainty, they're all the emotions that are coming out in this really challenging time. Like, I am in no way minimizing the stress of that 2 weeks. In fact, in an IVF cycle, I think that's the most stressful time. That 2-week wait from your embryo transfer to the pregnancy test. Put your hand up, give me some love if you agree with me. It is the most anxiety provoking time, but you've got to think about good coping techniques, right? So think about things that are going to improve your temple, going for walks, having a beautiful bath with appropriate essential oils, doing some meditation, taking yourself for a massage, getting on the phone to your girlfriends. These are all coping strategies that at the very least do no harm and probably actually do your mind, body and soul some good. Wine, cocaine, cigarettes probably aren't the things that I would be recommending as coping techniques probably ever, but coping techniques to use in this particular time in your life. So look after yourself, treat yourself, but probably not with a glass of wine during this really important time. Guys, thank you so much for joining me. I hope that if you did jump on, your questions were answered. Remember, what I talk about is as generic as I possibly can. If you have further questions about your own situation, please head along to your doctor and discuss it until you get the answers that satisfy you. Remember that this is all about empowering you with information, and if you think there is somebody else out there that would really benefit from this, please share this with them. And I will see you next Wednesday, and I do have a very special thing for you next Wednesday night. I can't wait. Just think, sexology. I'm saying no more. Have a good night.